Hey, it's Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today we're going to talk about turn frequency for expanders, whether you have fixed or removable expanders. Obviously, this is a removable expander. If you worked with me before, I'll usually, when we work on a phase 1 case, I'll give you the recommended turn frequency. It's just an estimate though. You really can't go just by that. And turn frequency will depend on a lot of factors, how the bite is fitting together in the back, what the intermolar width is, how constricted the palate is, how much crowding there is. There's a lot of things that go into it. The age of the patient, the skeletal maturity of the patient. So it's literally just an initial kind of estimate on what might be recommended. I tend to do things slower with expanders than faster just because I've seen so many scary things happen with like hemorrhage, not my patients, but crazy stuff happen with rapid expansion. So I like to take things slower and just keep an eye on them. I mean, why the hurry, right? Why the hurry? If you want to put braces on at the same time, then do a fixed one, but you can still go nice and slow. So I tend to do usually around 2 turns a week on a pre-pubertal patient and 1 turn a week on a post-pubertal patient. Again, I've got tons of videos on knowing the difference between that, and we're not going to go into that right now. But also, if you're doing upper and lower, and yes, I know lower doesn't have 2 palatal shelves, you're not actually expanding, all you're doing is widening the arch, and yes, you can do that with wires, and yes, you can do that with aligners. But if the child is in mixed dentition, it is amazingly helpful to widen those arches, especially if the lower one shows signs of crowding too, because then the teeth tend to come straight to begin with, or more straight to begin with, right? In an older kid, if it's got a lot of crowding, sure, you can put wires in and put brackets on and use open coil springs and slowly start to add them in, or you can just widen the arch with the expander and get more space right at the beginning. It just makes things easier to me, but whatever. So anyways, we might have different turn frequencies. We might be turning 2 times a week on top and 1 time a week on lower. It really depends on how the bite fits together. And when the patient checks in, I do recommend the patient checks in your office. I don't really recommend just virtual check-ins for expanders because there's a lot of stuff you should be checking, not only the bite. I like to see how they're turning it. I like to see how they're putting it in, how they're taking it out. I want to take a lot of pictures with the appliance in and out to check on the bite. So many things. I like to feel the roots just to make sure nothing is poking through, make sure they're not having discomfort. So I don't like to do virtual check-ins for expander checks. But, we might change things. Sometimes we're going to finish the lower one before the top one. Sometimes the other way around. Sometimes a parent is turning one correctly and the other one not correctly. Like maybe it's jammed or they're just not fully understanding how to turn it and they're doing fine with one arch, but the other one they're not. And the arch is responding in weird ways, like it's overturning. So that's why I like to see them in person. And I like to let the patient know, hey, we're going to start out with 2 turns a week on non-consecutive days on the top one and 1 turn a week on the lower one, but we might change things. When you come in 4 weeks, we'll double check and we'll let you know if we're going to stay on that schedule. So normally we're going to be turning for 10 to 13 weeks, 11 to 14 weeks, something like that. Might be less, might be more. So it really depends on how they respond, and every child responds totally differently to an expander. But this is a nice gradual way. That way you don't get that giant ugly diastema between 8 and 9. I hate that. It's so ugly, and everybody hates that. And this way is really helpful. So hopefully this is helpful for you to understand turn frequency and the variables that go into it, and how you really should keep on top of your patients, having them come in, checking with the appliances in and out if they're removable, taking progress pictures with the appliances in and out, as well as a tabletop picture of the appliance, because you can actually see the screw threads on the appliance. And by counting the screw threads, it tells me about how many turns have been done. I always like to compare what I see in terms of screw threads, because 4 turns in a cogwheel is generally 1 screw thread. So if it's with what they're saying they did doesn't match up with what I see, then either they're out to lunch and just not doing it, but most of the time they think they're doing it, they're just not doing it right. So they can get a little bit, parents can get a little bit, defensive, like, hey, I'm doing it. Yeah, I totally believe you are, but it can get tricky. Let me watch you do a turn and let's just see how you're doing it. And maybe we can find ways for you to optimize that turn a little bit better so that you're getting the outcome that we want, because what you're telling me is not what I'm seeing. So I want to know if there's a problem with your appliance, or perhaps maybe the cogwheel's defective, or perhaps you're just not quite turning it correctly. So, and 9 times out of 10, it's that they're not turning it correctly. So, all right, thanks so much.